Hello, everyone, and thank you for joining today's webinar. My name is Karen Biala, and I lead the international partnerships at ARC. I am delighted to introduce Dr. Eyal Zimlichman, who will provide opening remarks and a brief presentation. And then we will have 4 startup companies that will present for 10 minutes each. We hope to stick to the timeline that we've presented, and I request that since I'll be fielding the questions today, that you send your questions directly to me in the chat. Again, my name is Karen Biala, and I'll be taking them from there. And I'll now introduce Dr. Eyal Zimlichman. He serves as Deputy Director General, Chief Medical Officer, and Chief Innovation and Commercialization Officer at Sheba Medical Center. Previously, he held the position of Lead Researcher at Partners Healthcare's Clinical Affairs Department in Boston, and he was heavily involved in efforts to implement a strategic care redesign initiative there. He served on several advisory committees commissioned by the Office of the National Coordinator for Health Information Technology at the U.S. Department of Health and Human Services, and is chairing as well as participating in several committees at Israel's Ministry of Health. We'll now actually turn it over to Yaniv to provide a few opening remarks before Eyal begins.
Yeah, thanks. Very shortly, I would like to welcome everyone and to thank you all for joining us today. And also specifically thanks the Sheba Medical Center and the ARC Innovation Center headed by Dr. Eyal Zimlichman. This is a great initiative to host a medical webinar in times of Corona, and we thank them very much. Today's event is also the outcome of our efforts as a group of economic attachés of the Israeli Ministry of Economy and Industry in the area of Asia Pacific. And all of you, all our guests are here today, and this is the outcome of our efforts. We also would like, I would like to share with you the names, very shortly, the names of my colleagues. We are coming from the Israeli Ministry of Economy and the Foreign Trade Administration. And today with me are also the different economic attachés in Asia Pacific region. They are working with their local staff in each country. Mrs. Noah Asher from Japan, and Mr. Shai Zarivach from Australia, Mr. Degan Aloni from Thailand, Mr. Yav Seidel from Singapore, Mr. Yaniv Tessel from Vietnam, Mr. Tzli Lav from Taipei, and myself, Yaniv Goldberg from Korea. So I would like to take this opportunity and invite all of you to do the follow-up for today's event with us directly, with our local staff. And also I would like to thank again Dr. Zimlichman and his team and the entire Sheba Medical Center for hosting this very interesting event. Thank you very much.
Thank you, Yaniv, and thank you everyone for joining us. It's really our pleasure to describe to you our experience with COVID-19 and how we've handled this situation, especially focusing today on telemedicine as part of a much broader program that we've launched here, and I will explain that in the next few minutes. And of course, COVID-19, I think, brings the world together in that regard, between countries, trying to learn from each other, trying to understand what is working and what is not working. And I think global collaboration in these times of crisis is really peaking. And of course, it's one of the positive things we're seeing from such an event such as this pandemic. So in that spirit, it's our pleasure to share this information. And without further ado, I'll jump right into the presentation so we have more time also for questions at the end if there would be any. Before we jump into the topic of telemedicine, let me tell you a bit about Sheba Medical Center. So Sheba Medical Center, as you see here in the slides, I hope everybody can see the slides, is the largest medical center in Israel and also largest in the Middle East, one of the largest in the world, with about 2,000 beds all on one campus, with an acute care hospital, a rehabilitation hospital, a children's hospital, a large cancer center, and a women's hospital. One large campus, as I've mentioned, 200 acres, really a small city in any regards. You could see it in this photo, with about 24,000 cars that come in every day through our gates, 150 different buildings and so on. Really a very strong footprint in Israel, treating about 1.6 million patients every year, and a major powerhouse in research and innovation for the last few decades. Also recognized by Newsweek magazine in their top world hospitals as a top 10 hospital in the past 2 years. We came in as number 10 in 2019, and just in the list published a month ago as number 9 in the world. And of course, this is the first time ever that somebody tried to compile an international list. So we're very proud of that achievement, of course. Sheba is very proud also in its tradition for innovation. And some of you might know about the ARC program. The ARC program started about 3.5 years ago. Officially, we actually launched it 6 months ago, but we've spent quite some time building it. And ARC is a global ecosystem of innovation that started at Sheba and now includes many, many hospitals around the world and also strategic industry partners. It's basically sitting on top of 4 concepts. The first one is focusing on digital health as the main transformation vehicle that would create most of the impact on healthcare in the next decade. And within digital health, we're looking at the wide spectrum of digital health. You will see that in a second. Fostering open innovation, working together with the industry, breaking down the silos, tearing down the walls, to work together with startup companies, together with large industry partners, to really share a common vision and then work proactively to reach that vision. International collaborations, it's an international ecosystem. 15 of the leading medical centers around the world, mostly North America, but now more in Europe, and also looking to the East for some more partnerships. And we'll be happy to include the leading medical centers around the world with a very strong tradition of innovation to be a part of the ARC ecosystem. But collaboration is the C for ARC. ARC stands for Accelerate, Redesign, and Collaborate. And collaboration is a strategy. It's an important part of the strategy. And then finally, the innovation infrastructure, which is needed, both in terms of regulations and policies and methodologies of doing innovation, but also in terms of data infrastructure and physical infrastructure to foster innovation. This is what ARC stands for, and this is how this whole started. And we're getting, of course, to where ARC meets COVID-19 very soon now. So as we move over to the next slide, in terms of how we've been working at ARC, looking at 4 different floors of operation, if you might. Our own idea lab, where ideas are coming internally from the organization, the startups that work with us, and how we provide them with a startup-friendly environment to really accelerate their innovation, strategic partners from the industry that work very closely with us to develop new developments, and finally, the academia. We work with most of the major universities here in Israel in collaboration. And then through that, we have 6 hubs of our focus areas, from innovations in surgery and rehabilitation to telemedicine and big data and precision medicine and virtual reality. And this is cutting throughout the floors, through the internal ideas, the startups, strategic partners, and academia, of course. And when we look at ARC and our ARC hubs, these are the, again, the fields we're focusing on day to day. So before COVID-19 met us about 2 months ago, these were our fields of operation. This is where we were focused on. And some of you are more familiar with ARC and the work we've been doing. Of course, this is ongoing, and we're looking forward to work on all of these issues back once we get COVID-19 settled. But as you know, something happened, and we met COVID-19 first in February 16, just about 2 months ago, when the Diamond Princess, as you know, off the coast of Japan, had the first international patients with COVID-19 after China. And we had about 14 Israelis on board, and the decision was to bring them back to Israel. You probably have followed the news around the Diamond Princess. And Sheba was selected to receive those 14 patients and treat them here at Sheba. Excuse me. Since then, of course, we've seen many more patients, and you see here the graph of how we had COVID-19 here in Israel in the past 2 months. but you see now we have about 11,000 confirmed cases. This is updated from yesterday with a fairly low mortality of around 1%, actually very close to 1%, of 113 patients, again, in the past 2 months, and 181 severe cases with about 130 ventilated patients in the country. So not very high numbers. The population of Israel is around 9 million. Telephone and cell phones and emergency press and so on, and security cameras, but the Uniper was our main communication tool. You see here, this is the TV. You mount a camera on the TV. We use the devices like your router for cables, and there's a remote control that's very easy to use for elderly population. And through this, again, the TV turned into a communication station, and we were able to communicate between the staff and the patient, but also patients to patients in different rooms, different isolation rooms, and patients to family members who, of course, wanted to be in contact with their loved ones. So you see here a couple of examples. This is one of our patients during a video visit with one of our doctors. This is Professor Gili Regev, our infection control specialist, who is communicating with several patients. You see here on the screen, she's actually having a conversation with a few patients, telling them about COVID-19 and some of the precautions they need to think about. This is a social worker who's having a session with one of the patients. So again, all staff can use this, and patients are a few meters away inside their isolation rooms. Family room for virtual visits. Family could come to a different room we've placed on the side and communicate through the screen, or even communicate from their own home if they could operate it at their own home. This is a virtual family visit for a patient with delirium. You see the patient on the upper left screen, and family members at their different homes who can communicate with the patient or talk between themselves and have a group session with a specific patient. For monitoring, we've had, of course, self-examination and reporting of vital signs, but we also had another technology called EarlySense, which again, you'll hear more about later. And the technology with EarlySense is basically a sensor that is placed under the mattress, measuring continuously heart rate, respiration rate, and motion while the patients are in bed. There's an AI-based algorithm that can predict clinical deterioration. Now, why is that so important? It's so important because we know COVID-19 can follow a very benign course. The disease would be very mild, flu-like symptoms, everything seems fine. And then theoretically, and we see this a lot, we get a very quick deterioration with severe respiratory symptoms leading to the need for ventilation. We need to identify that ahead of time so we could take precautions. We could maybe transfer the patient to a higher level of care, maybe an ICU or a step-down unit, so that we could be ready for intubation if that is needed. You see here an example of the trend screen on EarlySense showing respiration rate and heart rate. Respiration is the blue line, heart rate is the red line, and you could see how both respiration and heart rate are going up in a patient who is starting to deteriorate. And those alerts can actually warn you before saturation drops and before the patient gets very symptomatic and crashes from a respiratory point of view. The technology has been in use in hospitals for many years now, including in Sheba, in some of our internal medicine wards, and has a lot of experience predicting sepsis and other types of deterioration. But now, because COVID-19 is mainly a respiratory problems, and the ability of the EarlySense sensor to measure respiration rate very accurately provides us with a very good tool to diagnose ahead of time deterioration of patients. For physical examination, we've used the technology called TytoCare, which allows us to perform the physical examination. You see here on this photo, basically the idea is that a doctor from afar can listen to the heart, and the lungs can look down the throat or into the ear. With this technology, either the patient uses it on himself, on the chest and back, or another family member is there with them to do this, or another nurse or doctor who's bedside can actually use the devices and record it and then listen to it in the control room, or have another doctor listen to it in the control room. You see here Dr. Gadi Segal, the head of the Corona medicine unit, who's listening to the hearts and lungs through the headphones and looking down the throat of a patient in isolation. I have to say we've had very good response from our clinical staff about using this technology And we have many, many doctors now using it. They think the quality is very good and allows them to make clinical decisions. And another technology is the InTouch Telepresence robot you see here in this photo. This is a robot originally designed for ICU. Of course, it provides us with an opportunity to bring this into isolation rooms and provide what we call telepresence, where a doctor, here Dr. Galia Barkai, for example, actually virtually walk into the isolation unit, converse with patients through the screen, and even perform some forms of physical examination through the robot. We have a couple of those robots, and the staff really enjoy using it much more than in typical ICU during times of non-COVID-19 pandemic. On the stage 2, we actually transformed the facility into internal medicine ward, including, as you see here, beds for ventilation when some of the patients started deteriorating. We simultaneously at the time also built our Corona ICCU, intensive care unit, with 80 beds for ventilated patients with Corona. And the goal was, again, minimal physical contact. You see here, this is the step-down unit where patients could be intubated. Of course, this is all in isolation. Then we used another device and another technology called BioBeat, which is a more advanced monitoring technology, using this device attached through a patch to the chest of the patient and measuring one lead ECG, but also blood pressure and respiration rate and blood oxygen saturation, and everything you see here on this slide allows us more information for those patients that are deteriorating, and providing the information through this dashboard, again, to the clinicians in the tent to make better decisions. On stage 3, we're preparing to send the patients home and preparing for home hospitalizations for patients that seem to have more of a mild disease. We've used the Datos Health app, which is our telemedicine platform. Everything hooks up to Datos, whether it's Bluetooth technology to measure vital signs, EarlySense technology, and other technology that hooks up into Datos. And through the app, we can communicate with the patients. There's a video communication and text communication. We could send text messages. We can send them other messages for communication, videos, and so on. And of course, monitor the patients. And this was, of course, set up for the asymptomatic and mild symptomatic patients who were hospitalized at home. You could see here the basic program for patients who are on observation, once a day video visit, reminders, and on-call infectious disease physician 24/7 for consultation to these patients. But then when the patients actually start with the disease and have mild symptoms, we turn this into an extended program that has twice daily video visits, physical exam with Title Care, continuous monitoring with EarlySense. And as you can see, we've actually made this kit, this telemedicine toolkit for COVID-19 that was placed next to the door for those patients hospitalized at home and provided them with all the technology they needed in one box to carry on home hospitalization. Once the home hospitalization was done and the patient was discharged, we would collect the technology, of course, sterilize it and get it ready towards the next patient who's hospitalized at home. And this is the Zero Touch Telemedicine Toolkit, monitoring with EarlySense or BioBeat, physical examination with Title Care and management through Datos. And again, the technology is what we've been using, but there are other alternatives to some of these technologies elsewhere in the world. But again, the idea is that you need to consider monitoring, physical examination, and management of those patients through a platform that allows you to streamline all of this data. We even build the Corona home hospitalization flow, as you can see here, from nurse reports to that necessitate a phone call to a video call, remote physical examination, reporting the electronic medical record, consultants that we could bring online, and ongoing prescriptions or new prescriptions. We also provided our regular customers, the patients that come to ambulatory treatments at Sheba with chronic disease, coming to the specialist clinics with an outpatient service. As you can see here, instead of coming to Sheba in these times where patients need to stay at home and trying to avoid them with exposure to possible COVID-19, we'd like them to stay at home, and we'd like to do the visits virtually through the Datos platform. And as you can see here, We have many, many clinicians at Sheba, you'll see this in a second, working through the datos to actually do these virtual visits when patients are at home without having them come out. You can see here within a span of a month, the number of telemedicine users at Sheba has grown up. Look at the numbers here, from about 20 to 30 providers in February to close to 1,000 users in April. And this uptake in day-to-day would never be possible. We actually had a plan to upscale use of telemedicine with the new Datos platform and to get to 50% of our staff, clinical staff, by the end of 2020. We got to more than that within a span of less than a month, which is really, really remarkable and can only be done in times of crisis. And of course, this is something which will help us after COVID-19 use telemedicine for the right causes. So really summarizing all the efforts from home hospitalization for corona patients to continuity of care for non-corona ambulatory patients to medical care for isolated corona inpatients, and finally research and innovation that is still ongoing with new devices, EarlySense, DocDoc respiratory monitoring, and Vocalis for voice diagnosis. This is some more work. We'd be happy to elaborate on those different opportunities. Just to say a word about the new Corona ICU, we've started about a month ago, again, very heavily based on technology. This is their control room with the glass that they could actually stay inside and follow all the technology to understand how patients are doing, the telepresence with the InTouch robot, and many other technologies that we don't have time now to go into, but we've extended those technologies into the ICU as well. And finalizing, this is a really high time for telemedicine, and telemedicine can provide a comprehensive service solution that is highly scalable. Technology already exists. We've been using that technology before COVID-19, but now there's another opportunity to minimize contact with the staff by using this type of technology and to providing care, whether it's inpatient or at home or outpatient services through the technology. Times of crisis present opportunities, and we think the COVID-19 pandemic might be remembered as the turning point for digital transformation in general, and specifically for telemedicine, as I've showed you in some of these slides. So definitely some opportunities, even in these difficult times of a world pandemic. And I think I'll end with that and see if there's any questions, if we have a few minutes for that. So thank you, and Karen, back to you.
Okay, if you have any questions, please send them directly to me in the chat. Okay, we'll give you another minute or so. So there's a request to show the last slide again. If we can go back to the last slide, please.
Yes, let's take that on, and please reach out. You know, if you need more information, we're happy to share the experience I've talked about. And there's much more that we don't have time to go into right now. But again, I think that these opportunities are something that this is the time to use them. This is the time to reach out, and this is the time to push on telemedicine, because there's an opportunity here. So whether you're a vendor and you have a technology that can be used to any of these reasons to provide better quality of care, minimizing contact with staff, minimizing exposure of patients who can stay at home and get treatments at home, all of that is of interest right now. And you know, even those in these difficult times, we're seeing some telemedicine companies that are doing very well, actually even raising money when these are very difficult financial times, as you know. But we think, again, telemedicine now, this is an opportunity on all fronts to push that forward.
We received a question about physical examinations. The question is, many physical examinations are operator dependent. Did it pose a problem with telemedicine?
So we, so of course, one of the things that we did not have enough experience, but really has changed dramatically in the past 2 months, is using this technology to do physical examinations. And I have to say, with about 90% of the users. 90% of the users, we're actually doing a survey right now and we're going to publish it. 90% have said this is very high quality. It allows us to examine patients just like as we were standing next to them. And as far as everybody is concerned, as you know, with this type of technology, you could be in a room next to the patient, or you could be 1,000 kilometers away. It doesn't really matter. The telemedicine technology allows us to do physical examination from afar, and this can go across countries and continents to that factor. So I think overall the message is, yes, clinicians, first of all, need to be open to using this type of technology, but if they are open to use it, the general sentiment is that it's very, very much like using a traditional stethoscope and other diagnostic tools for physical examination we're using, and the response we're getting from our staff is very, very good.
Okay, I see there are a few other questions, but we're going to move along to our next presenter, Ziv, who will talk about EarlySense's technology.
Hi, everybody. Thank you. Thank you, Sheba and Dr. Zindichman, and hello to all our friends from Asia. I'm going to share my screen. 1 second, please. So I'm going to introduce EarlySense, as Dr. Zindichman shared before. We are longtime partners of Sheba Hospital, and we were deployed in some of the internal wards in Sheba and in other hospitals in Israel and across the world. So what is EarlySense? EarlySense is a contact-free, non-invasive monitoring solution. It is a sensor which is placed under the mattress in a bed, and then it monitors the vital signs of the patient, heart rate, mostly heart rate, respiratory rate, and motion. The data is displayed either on a bedside monitor or on a central display station, which I will share with you later. So we are monitoring respiratory rate, which is a leading indicator of patient deterioration, and especially with the COVID-19, which is a respiratory disease. It is an essential vital sign to follow, and it can indicate a deterioration of the patient. We are FDA cleared and CE cleared, and we have regulatory approval in most of the Asian countries. We collect data twice a second, which enables us to provide continuous monitoring of the patient condition, and if we identify a deterioration, which means higher respiratory rate and changes in the trend, then we will notify the clinical team. Basically, it allows us to monitor a very large group of patients without the need to engage physically with them to take the vital signs, and it protects the patients and the medical team together. So in more detail, the sensor is placed under the mattress. It is then connected to a bedside unit that can have a display or not, and we continuously monitor the heart rate, respiratory rate, as you can see on this slide here. With COVID-19, basically our technology allows to monitor the patients without the need to expose the medical team unnecessarily. You don't need to attach anything to the body of the patient. The unit does not need any kind of recharging. So as soon as the patient gets on the bed, he immediately starts to be monitored. And the vital signs data can be transmitted outside of the room and be monitored by the team. Here you can see Professor Galia Rahav. She's the head of the infectious disease unit in Tel HaShomer, and behind her, you can see the EarlySense screen. So if we take a closer look, you can see that this streamlines all the beds. Basically, this is only an example, but you can see all the beds streamlined into one central screen, and you can see if there are any specific alerts. So this allows you to control a large group of patients in a contactless manner from remote without the need to take vital signs. And this way you can protect the team while still looking after the patients. So to summarize, EarlySense is a sensor which is placed under the mattress. Our algorithms convert the data into the actual vital signs and pattern. We are using AI-based, Dr. Zimlichman mentioned before, we are currently on a fast track to identify the patterns of vital signs for COVID-19, which will allow us to give accurate predictions of deterioration for mild patients. This is based on the data we are currently collecting at Sheba and in other hospitals as well. So thank you very much, everybody. If you have further questions, please reach out to us for our website.
All right, we have a question from Kunimi. We have a good disinfectant that supports metal, glass, plastic, etc., but we have not tested against coronavirus. Can someone help in your organization?
I'm not sure I understand the question, Karen, honestly.
Okay, we'll follow up on that one later following the webinar. Another question that we received is, how much is the system? I assume that's how much does it cost?
Yeah, there are different, the cost is related to quantity and of course to the specific market and to the type of deployment, and I'm not sure it's relevant for all the people right now on the presentation. So please feel free to reach out and we will give more commercial information.
Okay. And another question that we received is, can EarlySense work with an air mattress?
Yeah, it's a good question. Yes, we can. We were able to develop a sensor that cleans out all the noise from the air mattresses that interfere with our data reading, and we have shown very good results with air mattresses. Yes.
Okay. All right, seeing as we have no other questions, thank you, Ziv. We'll now move on to Rami from Uniper.
Thank you, Karen. Thank you. Can you hear me well?
Yes.
Very good. So I'm just sharing my presentation. Okay, so I'd like to thank Sheba for organizing the conference, and we are honored to be partners with Sheba Medical Center, and of course for welcoming our guests coming to this webinar. I'm Rami, I'm the CEO and co-founder of Uniper, and pleasure to present you with our solution. So what's Uniper all about? Uniper is a remote care solution for older adults. It's for patients, but specifically tailored for older adults. It's a tech-enabled service empowering older adults to be socially and physically active at home. It's not just the technology, it's the service that comes with it that I'm going to show. At the end of the day, helps addressing social isolation, depression, and other mental challenges. Uniper operates in the US, Israel, and now we also started in Australia. We are working with payers, with plans, HMOs, home health, mental health providers, senior care, SNFs, hospitals. Basically, anyone that needs to provide service for this population at risk, older adults that need better care, and a little bit about COVID-19, or specifically, and when it started, we were very honored and proud being selected by Sheba to be the main communication system and patient engagement within the hospital, within the COVID-19 department. And this is a picture that Eyal also presented, telehealth, he mentioned that, where the Prime Minister and the Sheba staff is basically doing the first calls with patients coming into Israel. So that's one of the settings. Later on, we will basically being deployed in other hospitals in Israel in order to communicate with those patients. And also HMOs, the support of the health ministry, selected Uniper basically to address population at risk at home, the senior population that being hurt twice by COVID-19. One, being the highest risk population, B, being in social isolations and loneliness, something that they suffer, during normal times, but being accelerated as a result of COVID-19. So COVID-19 brought specific issues and needs and challenges that needs to be addressed. As I mentioned, social isolation, mental challenges, a lot of the patients and the rest of the population without any symptoms, and most population are now being forced to be isolated, which will increase a lot of depression and mental challenges. B, the need for virtual care, fast setup, first easy to use. Uniper is able to do it in 48 hours. And the older adults, the population at risk, that's been the one being hurt the most as a result of this new world order. So Uniper, when we started, we saw older adults sitting at home, being isolated, watching TV 6 to 8 hours a day. And we said, why fighting it? Let's take a technology they're used to and turn that into an interactive community as the main channel to make them empowered to be socially and physically active, and turn that into a community. Uniper is basically an accessible technology. It's a box connected to any TV, not just a smart TV with a remote control, easy to use, and a camera that works on any TV. It's HIPAA compliant, it's multilingual, and that's the vehicle to provide care. Using that, we have created what we call the virtual senior living community. Includes 3 ingredients. It's accessible, very easy to use, both by the older adults and as a remote care solution. We already have it as a cross-platform solution, but definitely the TV is the most accessible one. Be it social, it's live and interactive. We have a lot of activities along the day. In the morning, yoga session, then fall prevention program, positive thinking, nutrition for diabetes type 2, and so on. And it's personalized. Our AI engine learns the needs and wants of the patients and the older adults in order to personalize the programming. From a technology perspective, we look at technology as the enabler for a service. We have the older adults, it's the connectivity hub, we have it cross-platform, whether that's web, mobile, tablet, and obviously the TV. We have a caregiver solution, so the caregivers are part of the overall solution. And the last one is a full telehealth solutions behind the scene being used by us to personalize the service, but also by our health partners in order to deliver care. Uniper being used as a telehealth for remote interventions, one-on-one, remote identification of conditions. We talk about the monitoring capabilities. Health education, we have a lot of built-in content around different conditions in order to improve the patient and the older adult status. Real-time information synchronization among caregiver, whether professional and non-professional caregivers, digitalizing the care plan, and the remote patient assessment, whether subjective or objective, by different tools. It's personalized, so we have a full user profile of the patient and the older adults, focusing on the emotional well-being, on the social, mental, and cognitive status, and obviously tracking whether medication was taken, whether they attended the different courses, and so on. Our service, since we are a tech-enabled service, we are coming with a built-in content to address social and mental and physical outcomes. Specifically when it comes to social, then loneliness and social isolation. We have techniques to create cohorts, so all different patients can meet other patients during while they are using the system. Fall risk reduction, general health education content, and addressing anxiety and depression using our CBT courses and so on. This is a typical routine. So we have live and recorded content. Each one of our courses is basically used in order to achieve a certain outcome. So all being translated into a cost saving for the healthcare system. Usability is very high. The users are using it, they are more than an hour a day. It's become part of their daily routine. It's drive a behavioral change. By the way, the reason they are embracing it because it's basically empowering them, and then bringing on the medical service on top of it increases the compliance because we are treating the member, we are trying to empower them, then bringing on all the medical aspects. And we've done studies showing that it's actually reducing depression, loneliness, probability of falls at home, and so on. Looking at it from a higher level perspective, we are basically taking the best of senior living and make it available at home, tailored and catered for the older population, which are at risk. So making them socially and physically active, healthy, using medication reminders, full telecare solution and preventive care, connecting, allowing them to be safe by connecting different monitoring and other aspects, and comfort, feeling independent at home by ordering different kinds of services. Well, being currently used by different verticals and use cases in the US and in Israel, by HMOs and payers. Some of the largest payers in the US are using Uniper for Medicare Advantage and Medicaid and duals, senior care, senior living, SNFs, and other types of organizations that are serving this at-risk population. And for different purposes, tech-enabled health and wellness service, patient engagement solution, remote care for the highest risk chronic patients, and hospitalization and rehab. So again, you have the details on the slide. Feel free to reach out. We'd be happy to provide more details and see how we can help during this crisis and also afterwards. Thank you so much.
Thank you, Rami. We received a question from Anne. How do you quantify the savings per member per month, and what cashable benefits are there?
Sure. So there are two levels in measuring these savings. One, we have done studies that shows that reduction by third party, over standard scales, so PHQ-9, UCLA, MHCSF. So there were third party social workers and other medical staff basically measuring before universal intervention, at T1, T0, T1, T2, and that's being translated by an health economist into cost saving. If depression costs $3,000 all-inclusive hospitalization, then that's being translated. And then now is also being done through claims, by measuring claims compared to a control group, ensuring the saving.
Okay, we have one more question that I'll take, which is, please tell us about the measures to prevent information leakage. I believe this is referring to cybersecurity measures.
Yeah, so we are compliant with different kind of standards, being GDPR, HIPAA for the US, HITRUST. We've done a lot of penetration tests because we are working with governments and different large-scale private or public or governmentally owned organization. So we'd be happy to provide more details on the information security if we get there. But we needed to comply with all of that, signing different BAA and so on.
Thank you very much, Rami. We're now going to move on to our next presentation on Untitled Care by Eyal.
Yes, hello everyone, nice to meet you. I'm Eyal Baum from Untitled Care. I will share my screen to give you a quick overview both about our company, about our product, and mainly, of course, focusing on our activity related to COVID-19. Okay, so just to give a background about what Untitled Care is, so as Dr. Eyal Zimlichman previously described, basically we enable a telehealth solution that enables the physical exam. We have a set of different connected devices in a kit, which is user-friendly, that allows basically anyone, anywhere, to do a physical exam, just like in the clinic. In terms of physical exam, what does it mean? We provide full connected devices, a stethoscope, which is highly relevant right now with the COVID-19 for the lung function and identifying wheezing or crackles or any infections in the lungs or some progress of the COVID-19. So the lungs exam with our stethoscope is definitely highly important now for the remote monitoring, but also heart function and heart rate measurement. We have an examination camera with a tongue depressor to look at the throat, body temperature using non-contact, forehead thermometer, otoscope for exam, skin camera. So basically, all the tools that are needed by the physician and he's used to have when he's doing a regular clinic or hospital visit, now are available online as part of a virtual visit. Beyond the physical devices, we have a full telemedicine platform on our cloud that both enables the remote physician using our web clinician app to get all the data either in real time or asynchronously and do basically the exam together with the patient. You will see later a video done by Sheba showing exactly how this is done. So we have also a mobile app on the patient side that guides the patient how to do it, and we have integration capabilities that provide the recordings as part of the medical record. Just a comment, some of our partners are using our full telemedicine platform end-to-end with our video capability. Some partners are using our integrated mode. You see here a glimpse mainly from the US, but we have many partners that maintain their own existing telemedicine platform with video solution while adding the layer of the physical exam with Tyto. Basically, we support two methods of doing a physical exam. One is the real-time, what we call online, and one is the offline, the asynchronous. In the asynchronous mode, what is unique to Tyto, remember, a physical exam is something that is usually done by physicians at a clinic, not by patients, not by consumers. So our app and guidance capabilities with AI basically help the patients how to do these examinations and reach an image, a video, or a sound that will allow a remote physician to achieve a diagnosis. I'll show a quick video of how it is done. So basically, let's say a mom having a sick kid with an ear pain. So we both teach her how to do it. And while she's doing the exam, we guide her in the canal and give indication once the eardrum was identified to allow ear infections, diagnosing ear infection. Same goes for throat. We identify the tonsils to make sure that, the patient opened his mouth wide enough so the doctor will be able to diagnose your tonsils and tell if you have some tonsillitis. And last example is with the lungs exam that we guide the patient where to locate it on the chest according to the lung lobes and giving ongoing feedback on the quality of the sound. So all of those tools are highly needed to allow anyone to do the physical exam. Basically, we have two product lines. One is Tyto Home War for patients at home, for families, chronic patients or the elderly, and Tyto Pro more for different use cases like home care, visiting nurses. We have now in elderly care facilities using Tyto, pharmacies, ambulances, etc. You can see a glimpse about our partners in terms of our business model. We always partner with a health provider like Sheba, like Clalit in Israel. We have most of our customers, by the way, are in the US. In Asia, we have Samitivej, part of VDMS in Thailand, which is already, and we'll elaborate it later, already use it in many hospitals for the COVID-19. Some of them are insurance companies. So this is a glimpse about our partners that we enable them to do telemedicine with a physical exam. So just elaborate on which use cases, on which type of usages Tyto could be relevant for the COVID-19. So definitely remote monitoring at home, visiting nurses or traveling the clinicians that are doing home visits or home care, triaging and screening either inside the hospitals or in some clinics. And by the way, here you see the nurse treating the patient, but of course we have wards where clinics are using like hot hubs that are placing Titer to allow do a triage without getting in contact with the patient. So senior care facilities, home care, this is definitely something we see in the UK now, in Israel, at the US, in Switzerland, in France, this where our partners are implementing Titer in elderly care facilities, and of course in quarantine sites, and I will elaborate it further. Here what I want to show you is a video done by Sheba showing the online live examination with Titer. We see Dr. Gadi Segal doing a physical exam with Titer and online visits to a patient with corona diagnosed patient. He gets like a kit that allows a physical exam.
שלום אורה, מה שלומך? אני דוקטור סגל, מהיחידה לאשפוזי בית של תל השומר, ואנחנו נפגשים עכשיו במסגרת המעקב אחרייך כחלק מקבוצת האנשים שיש להם קורונה. אני רוצה ברשותך למדוד לך את חום הגוף. אם תקחי לרגע את הטייטו, את המכשיר הקטן הזה, את תוכלי לראות שעכשיו אני מדליק עליו תמונה קטנה. עכשיו נמדוד את החום שלך, בלי לגעת, יופי. מצוין, אין לך חום בכלל, 36.9. עכשיו אנחנו עוברים לבדוק את הלוע. תפתחי פה גדול בבקשה. מצוין, אני לא רואה דלקת בלוע. הדבר הבא הוא להאזין לריאות שלך. תקחי בבקשה עכשיו את הסטטוסקופ ותחברי אותו אל המכשיר. תניחי בבקשה את המכשיר בנקודה מספר 1. תנשמי עמוק, פנימה והחוצה עם פה פתוח. פנטסטי. עכשיו לנקודה מספר 2, לנשום עמוק. מצוין, הריאות שלך ממש נקיות. את יכולה עכשיו לנתק את הסטטוסקופ. עכשיו אני שמח לבשר לך שהבדיקה שלך תקינה. אין עדות לדלקת ריאות. קצב הלב שלך תקין, סדיר. אין לך דלקת בלוע, החום שלך תקין. את יכולה להמשיך את המעקב של היחידה לאשפוזי בית שלנו, ואני בהחלט חושב שבתוך יום-יומיים תוכלי להשתחרר מהמעקב, ומאחל לך בריאות שלמה.
So this was Sheba. We are already also used by almost all hospitals in Israel in the quarantine section, 18 hospitals specifically. Another example, which is more relevant to Asia, is our partner in Thailand, Samitiv Edge, which is part of BDMS, that already deployed Titer for the group 48 hospitals. And also after the Prime Minister of Thailand saw a demo and was exposed to Titer, he gave his recommendation that followed that 200 hospitals now got a Titer device to use for the quarantined patients. And I will jump to a video done by Samitiv Edge that really explained from them. I will not show the entire video, but this will also show the value of Titer for hospitals in Thailand. Okay, so I will stop here. Just let's slide. This is another last slide showing we have like kiosk-like areas in hotels in Israel, in clinics in the US, patients can come, get the physical exam, get online with a physician, and know the status, whether they are in risk of COVID-19. So this is another use case we see traction in different areas. Thank you very much. Any questions?
Thank you, Eyal. We have a question about who is responsible for cleaning the devices after each use?
Yes, so usually it depends on the use case. You know, if it's the same one patient at home, so he can clean it with alcohol wipes, 70% isopropyl alcohol. This is our cleaning instructions. So those are either done by the patient themselves before or after they're being examined, or by the medical team. After a patient finish using it, the clinical team disinfects it with alcohol.
Great. Thank you so much. And we encourage you to, if you don't mind, reply to some of the questions in the chat. There were others that unfortunately we won't be able to raise now. We'll move on to our last presentation by Uli from Datos. And continue to send along your questions. If we don't get to them during the webinar, you can send them to us through email. I'll put our email in the chat box. And you can then we can follow up with you afterwards if you don't receive a response before then.
Thank you, Karen. Can you hear me okay?
Yeah, we hear you.
Very good. Thank you very much for the Sheba Hospital and for Karen for putting together this great webinar. My name is Uri Betesh, and I'm the founder and CEO of Datos Health. Datos is a fully automated remote care and a telemedicine platform. And when the corona outbreak started, basically Sheba, who is our partner, they put together a home hospitalization program and a virtual clinic program. Today, more than 1,000 physicians and doctors and nurses are using our virtual clinic inside the hospital, where basically we convert regular clinics into virtual in basically less than a day. That solution is very simple in the sense that the patient doesn't need to download a mobile app to log in into the video call with the physician. And they can just they get a text message, an SMS message with a link. By pressing that link, they can be directly with a video chat with their doctor. And another program that Sheba put together in the system, it's the home hospitalization program, meaning that to monitor positive COVID-19 patients at their own home. And by doing so, we protect the medical team from the positive patients. We enable larger scale of home hospitalization with very minimal resources, because the platform basically can manage automatically the patients. And we also allow isolated medical team to still provide care during the isolation process. So those are the two programs that Datos offers these days for the COVID-19 situation. Since then, basically, the Ministry of Health here in Israel contracted Datos, and today Datos provide a home hospitalization program throughout the entire Israeli healthcare system. In addition to in the United States, we both provide that service to hospitals and to the county level, meaning to the government. In addition to that, we also provide that service in Italy today, in Milan, and it's being implemented now throughout the Italian healthcare system as well. The Datos platform basically comprised from a dashboard for the medical team that aggregates all the patient's data, including blood pressure, temperature, pulse ox, and a daily symptom survey. You can see the daily symptom survey here at the bottom on our mobile app. and that survey is being scored. There is an algorithm to calculate the severity of the patients with the vitals that patient reported on, like temperature, blood pressure, and pulse ox. There is the ability to do video calls directly from our dashboards to the patient's app with the physicians. And there is a protocol about when to answer the survey, when to fill in the measurements, messages that are being sent automatically to the patients based on their conditions. And the main thing here is that the entire program can run automatically, and only in severe cases we alert the physician, the doctor, and allow them to do video calls with the patients. What we did in our platform is basically we configured a decision tree for the home hospitalizations of the COVID-19. It starts with a temperature or with a fever survey, and based on the different symptoms and the vitals, there is different recommendations that are being sent to the patients, and again, everything is being done automatically. There is the process flow of basically onboarding patients to our platform. The patients will get a text message, and then with a link to download our app, and then from that point on, the patients can start using our app and upload the data to the medical team. It is very important to remember that in these days, we cannot do onboarding face-to-face. We cannot do that physically. We have to do that virtually, and the platform supports that by communicating with the patients both with in-app notification and also via text messages to the patient. In addition to that, once the patient's logged into the system, there are, as I mentioned before, there are daily symptom surveys, ability to track your vitals like blood pressure, pulse ox, and temperature. There is the ability to do video calls, so only when needed, and also an emergency call when the patients would like to contact the medical team. They have also the options to do that. Here is a closer look about how the system looks from the patient perspective. We have the ability to integrate with connected devices. For example, you just looked at TytoCare. We are now working on the integration with TytoCare, so it will be seamless integrated. But it also can be we also can operate with very simple manual entry and save all the logistics around the connected devices. So it's a choice whether to use connected devices or whether we would like to do manual entry. As I mentioned before, for the care teams, there is a full dashboard that they can see all their patients sorted according to the severity of the situation, and they can basically go one after the other based on the different alerts and provide care from the comfort of their own home. As I mentioned before, the platform has four main components: the integration to devices, a personalized mobile app that can be tailored specifically for the specific patient. All the data goes into our HIPAA-compliant cloud, where we have our protocol engine, survey engine, and communication engine, and the data flows into the dashboard that I just presented to do data visualization, alerts, reminders, and all the other admin configurations. Thank you very much, and happy to answer any questions you might have.
Okay, please send along your questions. Okay, we have a question on PHR, and it is, can those PHR gathered by Datos be integrated into existing EMR systems in hospitals?
Absolutely, yes. We have a full integration with EMR, and yeah. So the answer is yes.
Okay. I'm just waiting for additional questions. Please send yours along to the chat. Okay, it looks like there are no other questions. I want to take this time to thank our presenters, Ziv from EarlySense, Rami from Uniper, Eyal from TytoCare, and Uri from Datos, both for sharing very useful information for various communities in Asia, and also for answering the questions that we received in the chat box. As a reminder, if your question did not get addressed, please feel free to email us at innovation@sheba.health.gov.il, and we'll do our best to respond in a timely fashion. Thank you again for your time and attention.